Imagine, if you will, a highly complex architectural reconstruction project. Like you are tasked with rebuilding the foundational supports of a multi-story structure.
Right, which is already a massive undertaking on its own.
Exactly. But, there's a catch. The building you are working on is constantly moving, it's breathing, it's shifting, and it's pulsing with blood flow.
Oh, wow. Yeah, that's an engineer's nightmare.
Right. And the structural supports you actually need to repair are essentially invisible to the naked eye.
Hmm.
And if you accidentally nick one of the nearby plumbing lines while you are working in the dark, it could cause a catastrophic system-wide failure.
Yeah, that terrifying high-stakes scenario isn't some theoretical engineering problem. That is the daily physical reality of pelvic reconstructive surgery.
It really is.
I mean, you are working in a confined, incredibly dynamic space. Surgeons in this field operate in an area where, the margins for error are measured in millimeters, and the material they are trying to rebuild is constantly under tension.
So, today, we are pulling from a fascinating stack of sources to explore this exact environment. We've got institutional reviews from medical journals like the European Journal of Cardiovascular Medicine, plus detailed surgical technique papers on pelvic organ prolapse, which is often called POP.
Yes, POP. And some really cutting-edge anatomical studies, too.
Right. So our mission for this deep dive is to explore the hidden, high-stakes world of pelvic floor reconstruction. We'll map out the hidden dangers surgeons navigate, specifically the alarming risk of urinary tract injuries.
Which are far more common than people realize.
Exactly. And we'll unpack the scrappy, brilliant innovations being used to fix our most delicate anatomy. So whether you are a medical professional, someone navigating your own health journey, or you are just fascinated by the extremes of human engineering, this deep dive is going to completely change how you view the construction of the human body.
Absolutely. Because to understand the surgery, we really have to understand the architecture first. The female pelvic floor is, it's an absolute marvel of biomechanics. Instead of thinking of it as a rigid floor, think of it as a highly dynamic suspension system. It's more like a multi-layered trampoline.
A trampoline. I like that visual.
Right, because you have this complex web of connective tissue, fascia, and muscle, specifically the levator antemuscle. And together they sling across the bottom of the pelvis.
Wow.
This trampoline is responsible for holding up the bladder, the uterus, and the rectum against the constant downward force of gravity,
Yeah.
all while allowing for essential daily functions like voiding and, of course, childbirth.
Right. So the trampoline has to be incredibly strong, but also incredibly flexible. But when that suspension system fails, like when the springs on that trampoline stretch out or snap entirely, we get pelvic organ prolapse, or POP.
Yes, and the statistics on this are they're staggering.
They really are. The sources note that up to 50% of Paris women, meaning women who have given birth, have some degree of prolapse on physical examination.
50%?
Yeah.
Think about that.
It's wild. And the Women's Health Initiative trial actually found that 65% of their participants had a prolapse of stage 2 or, 65%.
Yeah.
That means if you look at any room full of mothers, more than half are dealing with a structural foundation that is literally collapsing into the vaginal canal. Why on earth isn't this talked about more?
Well, there is a massive historical stigma around pelvic health,
Yeah.
which leads to a lot of silent suffering. For the patient, a severe prolapse physically alters their daily reality.
I can only imagine.
It can cause chronic pressure, difficulty emptying the bladder, and just profound impacts on their quality of life.
Yeah.
And for a clinician trying to fix it, you first have to accurately measure the extent of the collapse.
Right. And how do they do that?
They use a standardized clinical tool called the POPQ system, which stands for pelvic organ prolapse quantification. It's essentially a topographic map of the vagina.
Yeah.
Doctors measure specific anatomical points relative to the hymen while the patient is bearing down. Doing what's called a Valsalva maneuver-like, they are trying to exhale against a closed airway.
Oh, sure. Like when you pop your ears on a plane.
Exactly. So based on those measurements, they stage the collapse from 0, which is no prolapse at all the way to stage Y. And stage YV is complete eversion, where the organs have prolapsed entirely outside the body.
Wait, hang on. I have to challenge this measurement system for a second.
Go for it.
If the whole pelvic floor system is collapsing, then the hymen is collapsing with it, right? It's soft tissue. How are you measuring the severity of a prolapse against a ruler that's also falling down?
You've hit on the exact reason why clinical examination alone can be incredibly deceptive. The hymen absolutely moves.
Yeah, that just didn't make sense to me.
When a patient has a severe prolapse, They often have what we call descending perineum. The entire floor drops, so the hymens drag downwards along with everything else.
Which would totally throw off your measurements.
Completely. You might severely underestimate a posterior defect, like a rectus-seal where the rectum is bulging forward, just because your reference point has shifted an inch lower than it should be.
So what's the solution then?
That is why modern diagnostics are shifting heavily toward dynamic imaging. Transperineal ultrasound, for instance, allows doctors to see the prolapse in real time, but it doesn't rely on soft tissue.
Oh, what does it use?
It references the bony pubic symphysis, the bridged bone at the front of the pelvis.
Ah, okay, so an actual fixed anchor point.
Exactly. Using the bone as an anchor allows clinicians to actually see structural damage, like levator avulsions. That's where the muscle has literally turned away from the pelvic bone.
Oh, ouch, like a severe hamstring tear, but deep inside the pelvis.
Yes, exactly like that. And if you don't know that muscle has torn away from the bone, your surgical repair is highly likely to fail because you are trying to attach tissues to a foundation that just doesn't exist anymore.
Okay, so you get an accurate map of the collapse using ultrasound. You know exactly what has torn and what has dropped. Now, the surgeon has to go in and rebuild that trampoline.
Right.
But according to our sources, getting into this space means navigating a densely packed, highly vascular minefield.
It really is a minefield. A major institutional review by Jane and colleagues from the Raper Institute of Medical Sciences outlines exactly why this area is so treacherous for surgeons.
Yeah, the embryology stuff was fascinating.
It's wild, right? Embryologically, when a fetus is developing in the womb, the urinary tract and the genital tract develop from the exact same fundamental structures.
They start in the exact same place.
Exactly. They grow in incredibly close proximity. As a result, in the adult body, the bladder and the ureters, the tubes carrying urine from the kidneys down to the bladder, are intimately fused to the reproductive organs.
And that biological real estate leads to some really surprising rates of accidental injury during these reconstructive surgeries. I mean, overall, the rate of urinary tract injury in standard gynecological surgeries sits around 0.33%. But when you look at specific complex procedures, it just spikes.
It does.
For laparoscopic hysterectomies, it jumps to 1.8%. And in the Jane study specifically, looking at an institution handling highly complex cases, the overall bladder injury rate was 2.4%.
And we really have to look at the mechanics of those injuries. Because this isn't just a case of, bad surgery.
No, not at all.
These surgeons are operating in environments where the normal anatomy is completely unrecognizable. Think about that stage IV prolapse we just talked about, where everything is turned inside out.
Right.
The bladder isn't where textbooks say it should be. It's dragged downward and totally distorted. Add to that complications like a massively enlarged uterus or severe adhesions from endometriosis that essentially superglue the organs together.
Or intraoperative bleeding that completely obscures the visual field.
Exactly. You're working blind in some cases.
In reading through the prevention protocols for navigating that distorted anatomy, one phrase jumped out at me from the sources. It said, social distancing helps.
Yes.
I just found that so funny. The surgical guidelines literally advise surgeons to practice social distancing with the ureters.
It's a great term for it. Let's break down the biology of why that's necessary. The ureters are incredibly fragile tubes, and they have this delicate, microscopic vascular sheath around them called the adventitia.
Okay, the adventitia.
Imagine a major highway surrounded by tiny local supply roads. That adventitia is the network of local roads supplying blood and oxygen to the ureter.
Right.
If a surgeon dissects too closely to the ureter while trying to free it from surrounding scar tissue, they might not cut the actual highway, but they will completely bulldoze those local supply roads.
Oh, wow. And that causes an ischemic insult, meaning the tissue is starving for oxygen.
Exactly. Without blood flow, the tissue of the ureter becomes ischemic, eventually turns necrotic, and dies. So social distancing means the surgeon has to recognize the ureter, but consciously stay away from its vascular sheath entirely.
You just don't want to get close enough to strip away its blood supply.
Right.
But despite those precautions, there is a terrifying discrepancy in the data here. According to the systematic reviews, if a surgeon accidentally nicks the bladder, they spot it right away on the operating table about 80 to 85% of the time.
Because it's fairly obvious.
Right. They see it, they stitch it up, it heals. But a massive 60% of ureteral injuries are entirely missed during the surgery.
Yep, 60%.
Over half. If a surgeon damages a tube carrying urine, how on earth do they close the patient up without realizing it?
Because in the moment, there is no hole to see. The mechanism of the injury is usually insidious. As we just discussed with ischemia, or often with a thermal injury, the damage happens slowly.
Slowly, during the surgery.
Well, let's say the surgeon uses an electrocautery tool, which uses heat to seal bleeding blood vessels, and they use it a few millimeters away from the ureter. The lateral spread of that heat essentially cooks a tiny patch of the ureteral wall.
Oh, geez.
Or they place a stitch nearby that doesn't pierce the tube, but kinks it slightly, restricting its blood flow.
So on the operating table, the tube looks totally intact.
Exactly. There is no visible puncture. There is no urine leaking into the pelvis. But over the next 3 to 10 days, that thermally damaged or oxygen-starved tissue will slowly break down, slow off, and only then will it begin leaking urine into the abdominal cavity.
That is terrifying.
It is. And that delayed leak leads to severe peritonitis, or the formation of a fistula, an abnormal connection between organs.
So it's basically a rusted pipe that looks fine on the outside, but eventually just gives way. Which brings us to the detective work. If the leak doesn't happen immediately, how do surgeons find these invisible injuries before they finish the surgery? The intraoperative solutions detailed in the sources sound like a literal chemistry experiment.
They really do.
If they suspect an injury, they inject dyes directly into the bladder or the bloodstream. We are talking about methylene blue or sodium fluorescein, which literally makes the urine glow fluorescent yellow under the right light.
Which is very cool to see.
Yeah. Some urologists even pump sterile infant formula into the bladder because the bright white liquid stands out so starkly against the red tissue.
It's highly effective. But, those visual aids are helpful for immediate cuts. They still struggle to catch those delayed ischemic injuries.
Right.
And this brings us to a massive technical challenge in pelvic reconstruction, specifically regarding how clinicians verify they are operating in the correct anatomical plane when everything is so heavily distorted by a prolapse.
This is exactly what I wanted to dig into,
Mm-hmm.
because the distortion is the whole problem.
Right. So let's say a surgeon is trying to fix a collapsed anterior vaginal wall, what we call a cystocele, where the bladder is basically falling into the vagina.
Okay.
They often need to place a supportive mesh sling. But they have to place that sling strictly in the sub-mucosal plane. That is a razor-thin space directly between the vaginal skin and the bladder wall.
And as we established, the anatomy is already stretched, thinned out, and totally mangled by the prolapse itself.
Yes.
So how do they verify they're actually in that microscopic submucosal space and haven't accidentally pushed their needle straight through the bladder wall or the urethra?
Right. They rely on a technique called hydrodissection.
Hydrodissection.
Yes. Before making a single incision, the surgeon takes a syringe and injects a tumescent fluid, usually a mix of local anesthetic, saline, and a bit of epinephrine to constrict blood vessels, and they inject it directly under the vaginal mucosa.
Wait, so they are literally pumping fluid into the tissue to artificially balloon the layers apart?
Precisely. The fluid expands that microscopic submucosal space. It physically pushes the bladder away from the vaginal skin and creates a safer, wider plane to work within.
That is so clever.
It is. But even with hydrodissection, when you are passing long, blind needles through the retropubic space to pull a mesh sling up into the pelvis, you cannot rely on tactile feel alone.
Right, which is where the absolute game changer comes in, universal intraoperative cystoscopy.
Yes. The cystoscopy is the final verification. After placing the mesh or the needles, but strictly before finishing the surgery, the surgeon inserts a cystoscope, which is a rigid camera with a 70-degree angled lens, directly up the urethra and into the bladder.
Okay.
They fill the bladder with fluid so it expands, and they inspect the entire organ from the inside.
Wow. Looking at it from the inside out.
Exactly. So if one of those blind needles accidentally pierced the bladder wall, they will see the metal gleaming right there on the monitor.
Unmistakable.
Unmistakable. And if the mesh sling they placed in that submucosal plane is pulled too tight and is, say, kinking the urethra, they will literally see the mucosal folds closing in on the camera.
That is incredible. And by using routine cystoscopy, the detection rates of urinary tract injuries skyrocket from roughly 18% to 95%.
It's a massive difference.
Hold on, 95% detection compared to 18%? That's an unbelievable gap.
It is.
So if putting a camera in the bladder is that effective at catching these catastrophic injuries, is there any excuse for a surgeon not to just look inside every single time they do a pelvic surgery? Is the camera equipment just too expensive?
Well, it is less about the cost of the equipment and entirely about training and institutional policy.
Really? Training?
Yeah. Urogynecologists, surgeons, who spend their entire careers specializing in this specific intersection of the pelvic floor and the urinary tract. They strongly advocate for universal cystoscopy. They do it every time.
Sure.
But many pelvic surgeries, like routine hysterectomies, are performed by general gynecologists.
Oh.
The sources, specifically a major study by Peter L. in the International Urogynecology Journal, point out an urgent need for all operating gynecologists to become competent in cystourethropy.
Because it's not a standard part of their baseline training?
Not to the level needed for this.
Yeah.
It requires extensive training to accurately interpret what you are seeing on that monitor, especially inside a bladder that might be tented or distorted by surgical retractors.
That makes sense.
However, the data is completely clear. Institutions that mandate universal cystoscopy policies see their delayed urologic injury rates drop down to virtually zero.
Amazing. So now that cystoscopy ensures we aren't accidentally sewing the bladder shut or kinking the urethra, we actually have to reinforce this collapsed trampoline. We have to rebuild the pelvic floor.
We do.
But historically, the materials used to rebuild it became a massive scandal of their own. The sources break down two main pathways for reconstruction: native tissue repair and mesh repair.
Right. Native tissue repair is the traditional approach. The surgeon uses the patient's own existing fascia and ligaments to fix the prolapse.
Just using what's already there.
Exactly. For example, if a patient has a rectocell, the surgeon might perform a posterior colporrhaphy. They dissect into that sub-mucosal space we just talked about, find the torn, overstretched edges of the rectovaginal fascia, and plucate them.
Placate them.
They essentially fold and stitch the patient's own tissue back together to reinforce the wall.
Okay, got it.
There is also an obliterative approach called a colpoclysis. For elderly patients who are no longer sexually active and want a definitive lower-risk fix, the surgeon effectively pushes the prolapsed organs back up and surgically closes the vaginal canal entirely, sewing the walls together.
Wow, but the native tissue approach, the regular repair, has a flaw, right?
Yes, it does.
If the patient's own tissue was genetically or mechanically weak enough to completely collapse in the first place, sewing that exact same weak tissue back together means the prolapse has a high chance of just happening again.
Right. The recurrence rates can be frustratingly high.
Which brings us to the elephant in the room: surgical mesh. It is impossible to research pelvic reconstruction without hitting the controversies. The sources heavily reference the 2011 FDA warning regarding transvaginal mesh for pelvic organ prolapse.
It is a very big deal.
Yeah, they noted that severe complications were not rare. We're talking about the synthetic mesh eroding through the vaginal wall, chronic debilitating pelvic pain, and severe dyspareunia, which is painful intercourse.
The mesh debate fundamentally altered the landscape of urogynecology. The underlying engineering concept behind mesh makes total sense.
Right.
If native tissue repairs fail because the material is weak, you introduce a permanent synthetic scaffold to reinforce the foundation.
Makes logical sense.
But the transvaginal delivery of very large, dense mesh kits for broad pelvic organ prolapse led to unacceptable complication rates. The vaginal tissue is incredibly thin and subjected to a lot of friction, and large pieces of synthetic mesh were simply eroding right through it.
That sounds horrific.
It caused a massive necessary shift away from their use in prolapse repair entirely. However, it is absolutely vital to distinguish between those large meshes used for prolapse and the much smaller midurethral mesh slings used specifically for stress urinary incontinence.
All right, the sources make a very clear distinction there. The small midurethral slings are still considered the gold standard for treating incontinence.
Absolutely.
But even those smaller, safer slings come with a massive barrier to entry for patients globally. Which brings us to one of the most fascinating, scrappy workarounds in our entire stack of sources.
The economic factor of healthcare innovation.
Exactly. Because in developing nations, the commercial surgical kits for a tension-free vaginal tape, or TVT, can cost around $500 US.
Right.
In a country where the average monthly income might be a fraction of that, a $500 single-use kit is entirely prohibitive. Millions of patients suffering from severe incontinence simply go untreated.
It's a huge disparity in care.
But a study from the Jawaharlal Institute of Postgraduate Medical Education and Research in India documented an incredible resource-conscious solution. They developed a procedure called STOM, which stands for Self-Tailored Ordinary Polypropylene Mesh.
Yes. The ingenuity of the STOM procedure is brilliant because it just deconstructs the commercial product into its basic materials.
Right. Why pay a markup?
Exactly. Instead of buying a $500 prefabricated kit with a pre-cut sling,
Huh?
the surgical team buys a standard large sheet of ordinary surgical hernia mesh.
Which is everywhere.
Hernia mesh is incredibly cheap and widely available. They sterilize it and literally cut it to the exact size they need in the operating room.
I love that.
But the innovation doesn't stop with the mesh itself. The expensive commercial kits come with proprietary, single-use, disposable needles designed to pass the mesh blindly behind the pubic bone.
Right.
The surgical team in India designed specialized stainless steel helical needles. They are completely reusable. They can be sterilized in an autoclave after every single surgery and used indefinitely.
That's amazing. And here is the kicker that changes the game entirely. They performed this STOM procedure under local anesthesia with mild sedation, running it as a daycare procedure.
Yes.
By utilizing that exact tumescent hydrodissection fluid we talked about earlier, pumping the local anesthetic directly into the submucosal plane, they entirely bypass the need for an anesthesiologist and general anesthesia.
It's a massive cost saving.
Right. The patient is awake, comfortable, their airway isn't intubated, and they walk out of the hospital the very same day. When you combine the self-tailored hernia mesh, the reusable stainless steel needles, and the elimination of general anesthesia, this team dropped the cost of this life-changing surgery from $500 down to $12.44.
It's practically unbelievable. And if you look at the clinical outcomes, they achieved a 90.4% success rate with minimal complications.
Which is phenomenal.
That is statistically on par with the clinical outcomes of the $500 commercial kits.
$12.44 for a 90% cure rate. To you, the listener, this is exactly why this deep dive matters. It shows that the bleeding edge of medical innovation isn't always about million-dollar robotic arms or some unpronounceable synthetic compound developed in a lab.
Right.
Sometimes true innovation is about brilliant, scrappy, resource-conscious adaptations. It's about democratizing life-changing care for the people who need it most, using the tools you already have.
It perfectly illustrates that an intimate, masterful understanding of the human architecture, knowing exactly where the endopelvic fascia is, knowing how to safely navigate the vascular supply of the bladder, is ultimately far more valuable than possessing the most expensive disposable surgical tools on the market.
Absolutely. So let's recap this incredible journey. We started by understanding the structural collapse of pelvic organ prolapse, picturing the pelvic floor not as a static bone, but as a dynamic, tension-loaded trampoline. We navigated the dangerous surgical minefield of the bladder and ureters, learning why ischemic injuries happen and why social distancing is a pelvic surgeon's best friend.
Can't forget the social distancing.
Never. We uncovered the vital detective work of hydrodissection and universal cystoscopy, proving that putting a camera inside the bladder is the ultimate verification tool for submucosal safety. And finally, we looked at the evolution of reconstruction, from plicating native tissue to the incredible $12 STOM mesh innovation.
It's been a lot of ground to cover. But the ultimate takeaway here for you is that knowledge is your greatest asset. Understanding the immense mechanical complexity of the pelvic floor and the inherent risks of repairing it is absolutely essential.
Yeah.
Whether you're advocating for your own health care, supporting a family member through a diagnosis, or discussing surgical options with a clinician, knowing about things like the necessity of cystoscopy or the fundamental difference between native tissue repair and mesh. It empowers you to make truly informed decisions about your own body.
Which leaves us with a final, lingering question to ponder as we wrap up this deep dive. We've spent this whole time exploring the extreme lengths surgeons go to fix this biological building once it falls. But as diagnostic technologies like 3D perineal ultrasound and AI tissue modeling become exponentially more advanced, will we eventually move away from these devastating surgical repairs entirely?
It's a fascinating thought.
Imagine a near future where a routine postpartum ultrasound doesn't just check your healing, but maps the exact microscopic tensile strength of your individual pelvic ligaments. Imagine an AI predicting a severe prolapse decades before it ever happens, allowing us to intervene early with targeted biological support, preventing the collapse before the foundation ever cracks.